Good morning. Welcome to our dementia workshop, Understanding and Responding to Dementia-Related Behaviors. I'm Eric Rohr. I'm the owner of Assisting Hands in Richmond, Virginia. Thank you for joining us. And I'm joined by Brooke Brockdorf. I'll have to use your new name here, Brooke, at some point.
I know. I got to change it all. That's the next step. It takes a while. So Brockdorf right now is fine.
Okay, so Brooke is with Brookdale in Midlothian, Virginia, which is right here in the Richmond area. And so I'm going to turn it over to Brooke to talk a little bit about our workshop series, and we'll take it from there.
Okay. Good morning, everybody. Yes, thank you for joining us. The understanding and responding to dementia-related behaviors is our topic for this month. We do our workshops on the second Thursday of every month. Typically they're at 10 a.m. We leave the time though for future workshops to be determined, because if we were to ever get any feedback saying that maybe an earlier or later time might work for more people, we're always open to being able to change that time, just because we want to make sure that our information and these workshops, as many people are able to join as possible. So between me and Eric and I and Cathy, we had really kind of put our heads together, and there's a lot of information out there in regards to dementia, different types of dementia, that they're just unknowns, and it's not to people who have never experienced anything like it before, whether themselves or someone that they love. But even people in the medical profession, there's a lot of things that it's new information or things that they didn't think about or didn't understand that maybe that's what it was. And so through all of that, we felt that it would be a great service to the public, to anybody and everybody, to try and help them kind of understand the disease and tips on trying to make it as positive as possible for themselves and their loved ones. So yeah, so thank you guys all so much. Like Eric said, I'm with Brookdale Senior Living in Midlothian. I love my seniors. I love my families. It's definitely, it's not just a passion. I truly believe what I do is a calling. And I can say the same for Eric and his team there, and Cathy as well. So it's my pleasure and honor to be able to host these with everybody. So that's enough of me speaking. I'm going to turn it over to Cathy to introduce herself, and we can get started.
Thank you, everybody. Once again, I look forward to this upcoming workshop, and I think we'll have a great time. And if everybody's ready, we'll go ahead and get started. Our workshop goals today, hopefully you'll walk away with a better understanding of what dementia is. We can identify some common triggers for behaviors that are often associated with dementia. There is a 4-step process that we use for assessing and identifying some of these challenging behaviors that I think will help. We'll have a list of strategies to address challenging dementia-related behaviors. And then we will give you some resources available to families and individuals living with dementia. And it's my personal hope that this workshop will help ease the isolation and frustration that often comes with brain change, and help you to appreciate the new ways that you and your person living with dementia around you are experiencing the world, and help you feel connected a little more to the people you love and you want to love, so that together you and the person living with dementia can live your best life possible. But before we actually get started, I want to start with our first poll question. Eric, are you ready? We'd like to know what kind of experience you have with individuals living with dementia. Are you someone that you are having dementia yourself? Do you know someone or love with someone living with dementia? Are you a professional providing care for someone living with dementia, or just want to learn a little more? Give you a few minutes to give us a little answer here.
Good, we're getting a lot of responses in. I'll leave it open just for another second or two. Great. Yeah, so it looks like we have pretty good spread. We have people that are professionals in the industry that are helping provide care for people living with dementia. We have some individuals, and obviously a combination of that. And then we have a few that just want to learn more, which is great. And I love that because I'm big on the education and awareness. We can't completely avoid dementia in some cases, but we certainly can do some things to mitigate it. The chances of getting it more, but once we get it, these dementia workshops are really set up to help enhance the caring and the life of the person with dementia and the families of people with dementia. So that's great.
Okay, well, we'll start with a review of things that we've already learned about dementia in past workshops. Dementia is the umbrella term for a person's decline in memory and other cognitive abilities that are severe enough to interfere with their daily life. It is not a part of normal aging. It's estimated that approximately 50 million individuals, with 5 million in the United States, are living with dementia today. This number will almost double every 20 years, reaching 75 million in 2030 and about 131.5 million people in 2050. And just so that you know, with all of the research going on, they have currently identified over 100 different types of dementia, and more is being determined every day. There are 4 truths about dementia that we have to understand. At least 2 parts of the brain are dying. It keeps changing and getting worse. It's very progressive. It's not curable. It's not fixable. It's chronic, and it will result in death. So that makes it terminal. Right now, there are 4 main types of dementia that people are familiar with the first being Alzheimer's. And though not all causes of Alzheimer's are known, a small percentage is related to gene mutations that can actually be passed down from parent to child. And then we have dementia with Lewy bodies that's caused by abnormal clumps of proteins that are found in the brain. There's vascular dementia that can be brought on by several different types of things, but this is caused by damage to blood vessels that supply the brain. Strokes is a very good thing with vascular dementia. And then we've got the frontotemporal dementia. And this is a group of diseases that's characterized by the breakdown of the nerve cells and the way they connect in both the frontal and the temporal lobes of the brain. And just as a little side note, autopsy studies of brains in people over 80 who had dementia indicate that many of them had a combination of causes: Alzheimer's, vascular, and Lewy body being the 3 chief offenders. So when we come to understanding dementia, there are causes and risk factors that affect most of us. Advancing age is one of them. Age is probably the biggest factor, but dementia can also affect people as early as 40, 50s, and 60s. Having a family history puts you at a greater risk of developing the disease. Genetics plays a big part. Huntington's disease can appear as early as 40, and also many people with Parkinson's disease will develop dementia. Other risk factors and brain health could be from alcoholism, drug addiction, diseases like diabetes, and many people with Down syndrome will develop early onset of Alzheimer's by the time they're in middle age. Dementia is caused by damage or loss of nerve cells and their connections in the brain. So depending on the area of the brain that's affected by the damage, dementia can affect people in a lot of different ways, and there's certainly a lot of different symptoms. But here are the most common things that we see: memory loss that disrupts daily life, challenges in planning or solving problems, difficulty with completing familiar tasks, confusion with time or place, trouble understanding visual images and spatial relationships, new problems with words in speaking and or writing, misplacing things and losing the ability to retrace your steps to find them, decreased or poor judgment, withdrawal from work or social activities, and changes in mood or personality. Dementia behaviors are usually triggered. Unmet needs are often the triggers of behavioral changes. It could be pain or discomfort, could be overstimulation or boredom, could be too loud or too quiet. Fear or frustrations is a big trigger. Unfamiliar surroundings, even changing familiar surroundings just ever so slightly can cause behavioral changes. Complicated tasks. Some of the things that we see when these triggers hit are anxiety or agitation, a lot of pacing, a lot of fussing, confusion or suspicion that come with accusations. There is often aggression with hitting or pushing and shoving. Repetition, we've all been there with that one, with repeated stories, repeated questions, and then wandering. And a lot of times wandering with a purpose, trying to get somewhere where they just can't quite remember the way to get there. So when we're trying to understand and addressing the behaviors, these are the 4 primary steps that I want you to try to remember to understand and address. The first, we're going to try to detect and connect. We'll address physical needs. We'll address emotional needs. And then you'll want to reassess and plan for the next time. So step 1 in detecting and connecting. First, we want to join the person in his or her reality by trying to see the world through their eyes. Understand what their reality is in context before we're intervening. So we're looking at who, what, where, when, how, and what took place before, during, and after the behavior. And then approaching the person calmly and respectfully from the front with a smile on your face, and try to diffuse the situation initially with a friendly demeanor. In step 2, we're going to address physical needs. It could be medical issues starting with pain. So you want to visually assess, are they walking funny? Are they rubbing their head, their hands, or their tummy? There could be physical problems such as hunger or thirst, lack of social interaction, isolation from others, just sitting in front of a TV, staring blankly. Do they need to use the bathroom? Are they tapping their feet? Are they pulling at their clothing? Are there any medication reactions that are going on? Do they seem to be agitated right after taking medicine? Are they lethargic? Things of that nature. And then, of course, we want to look for environmental triggers that cause discomfort. Restrictive clothing, it can be too tight, but also clothing that is too loose can cause uncomfort. Room temperatures are a big thing. For someone living with dementia, trying to keep temperatures at a constant level are a really good idea. Lighting with glare or sounds. Loud noises or sounds can be very confusing, so it's best to keep slow, easy, rhythmic sounds to soothe. And there's also a new thing that they've come out with called bright light therapy. It's a promising new treatment that is thought to affect brain chemicals related to mood or sleep. And specifically, the use of bright daytime lighting can help address some of these physical needs. Then, I'm sorry, we skipped step 1 here. We're going to go to step 3, where we'll address our emotional needs. So think about how that situation might feel to the person living with dementia. Focus on their feelings and not the facts. Remember, we're in their reality now. Reinforce that you are here to help. Smile, use hand under hand, anything that can just give them some positive reinforcement. Use your knowledge of the person's preferences to provide effective interventions. What were their coping mechanisms prior to their brain change? Did they like to walk? Did they exercise? Did they do arts and crafts, cooking, things of this nature? And then redirecting energy into a much more soothing activity for them. A lot of times soothing music, looking at pictures, folding clothes or towels, just something that they can gently de-stress with. And then step 4 will be to reassess and plan for the next time. So you'll go back to detecting and connecting, joining their reality, what went well and what didn't go so well, and what kind of adjustments can you make? And then you're going to think about and create an intervention plan that includes who can help with the assessment and intervention, what to try and in what order, and what to do if the situation escalates. So let's start with applying our four-step process, which will go into behavior identification. We'll do some scenario descriptions, and then we'll use our 4-step process: detect and connect, address physical needs, emotional needs, and then reassess for the next time. So with behavior number 1, we see anxiety or agitation, which could be restlessness, pacing, distress, or over-reliance on caregivers. So let's start. Anne is a 75-year-old lady living with Alzheimer's disease, was pacing in the hallways in her house in the evening saying, "I need to go, I need to go." She would not stop walking, not even for meals. Her family would give her sandwiches to eat while she was walking. Though she used a cane, she was getting blisters on her feet and had lost a lot of weight from not eating. Her family would ask Anne to sit down, but as soon as she sat, she would immediately get up and start pacing again. As some background, Anne had worked for 40 years as a nurse on the night shift, and her agitation usually begins every evening. Her shoes are worn and she appeared to be in pain as she walked. So the first thing we want to do is to step 1 is detect and connect. The pacing begins in the evenings. So is Anne starting to sundown? Ask Anne where she needs to go and then offer to help her get there. Redirect by stating, "Okay, but before we go, it's time for dinner. Should we eat first?" So step 2 is going to be addressing her physical needs. She appears to be in pain as she walks. Are her shoes comfortable and in good shape? So one of the things that we would want to do would be to check inside of Anne's shoes for things that could cause her feet to hurt. Are there little rocks or pebbles in there? Or do we need to readjust the tongue of her shoe to make it more comfortable? Is Anne getting enough exercise during the day? A regular exercise routine can disperse with the excess energy, making it easier to control evening pacing. Offer to go on walks outside, go to the park, go to the garden. Now that the malls are back open, we can walk inside malls with masks. Anne is showing visible signs of weight loss. So we need to make sure that she's keeping healthy snacks available and offer frequently along with fluids. And understand that finger foods are okay. She doesn't necessarily have to sit down and have a 3-course meal 3 times a day. We also want to address Anne's emotional needs because we want the person living with dementia to feel more comfortable. So you acknowledge and you understand Anne's feelings and the need to go. We want to provide reassurance, companionship, and offer to engage in maybe a different soothing activity. Maybe it's something where we'd like to invite Anne to sit down and look at books or do adult coloring pages, things of that nature. Engage in conversations about her nursing days, helping her to remember her years of helping others. This is oftentimes very soothing to emotional distress. Ask her about a favorite patient she had, a favorite doctor she worked with, or maybe a favorite unit in the hospital. Then what we next will do will be step 4, to reassess and plan for the next time. Always assume that there will be anxiety and agitation because this disease is progressive. So we want to maintain regular routines, including exercise and meal times. Changes in schedules can cause extreme disappointment, frustration, and fear. We also need to avoid extremes in social situations. Being left alone for long periods of time or becoming overwhelmed by being around too many people can also not only cause physical stress, but emotional stress. Also keep in mind that noisy, poorly lit, or improperly heated areas can also cause increased agitation. Just a quick poll question. Has anyone experienced any anxiety or agitation in caring for someone that they love? How are we doing, Eric?
Yeah, we're getting quite a few responses. It looks like there's several people. I'll publish the poll results. Yeah, so it looks like there's a lot of people that have dealt with agitation or anxiety.
Okay. All right, let's talk about our second behavior, which is confusion or suspicion. The person may not recognize familiar people, places, or things, depending on where they are in their disease. They may forget relationships or names for people and common items. This confusion can result in the person suspecting others of theft, infidelity, or other types of improper behaviors. So let's take a look at Anne again. When Anne's family comes to visit and the evening begins, she becomes very suspicious that people are trying to get into her home and are watching her through the big picture windows. She becomes suspicious of her family for not making the people go away, and that they all must be in cahoots with each other, because this is where her confusion is at the moment. So for us, step 1 would be, again, to detect and connect. Is Anne reacting to someone in the present, or something that she has imagined, or something that's happened in the past? So what we need to do is to reassure Anne and check the environment for potential sources of confusion. The first thing would be to address her physical needs. Rule out an infection such as a urinary tract infection. These can cause quite a bit of confusion and suspicion in elderly people, but especially those living with dementia. You want to review the side effects of medications, as some of these can cause increased hallucinations. Is Anne seeing the reflection of family members in her window? Try pulling the drapes or closing the blinds as the evening approaches so that she doesn't see these things. Respond with a brief and accurate explanation, but avoid arguing. We all know arguing is not going to do us any good. Lack of sleep, poor eating habits can also cause agitation and confusion as well. We also want to address Anne's emotional needs. Briefly acknowledge her feelings and let her know that you understand and we're going to take care of the situation. And sometimes you might want to offer to take care of it together. Agree, validate, and apologize as you need, remembering again that we've entered their reality. And try not to take the person's confusion personally. This is the disease causing accusations and distrust. It is not a reflection of the person's feelings for you. So we want to reassess and again, plan for the next time, step 4. So you might want to show photos and other reminders to trigger recognition and to alleviate some of the confusions and suspicions. Take down mirrors, increase or decrease lighting or noise levels as you need to. Play soothing music, old TV shows like Lawrence Welk. Use scented diffusers with lavender and chamomile. Those are really good emotional stress lighteners. We want to sometimes provide multiple items that are often lost or misplaced, like glasses, keys, slippers, pens, and pencils. And keep in mind that although not grounded in reality, the situation is very real to the person living with dementia. They're trying to make sense of how his or her world is changing with their declining cognitive functions. And remember, this is not always about diffusing the situation, not convincing the person living with dementia that this is the truth. So again, another quick poll question. How many of you have run across confusion or suspicion living with someone living with dementia? How are we doing with that? Okay.
Yeah, wow.
Yeah, quite a bit.
Yeah, quite a bit. Yeah. and
Quite a bit.
I don't know
Yeah.
if you saw in chat, Susan shared about a friend of hers took her mother into the home and the mother complained of a person in the room and it was the mirror. And they removed the mirror and the behavior stopped. So I think that's a great, thank you for sharing that, Susan. And I think that's so important about connecting and kind of getting in their places like, okay, we wouldn't have, we're thinking there's an actual other person, but knowing that they're seeing someone in the mirror and they're not able to differentiate is a really good example. So thank you, Susan, for sharing that example.
Okay, let's go on with our third most popular behavior, and that is aggression. And aggressive behavior can be verbal, it can be physical. It can be very sudden for no apparent reason, or it can emerge following a trigger. It can also occur because the person living with dementia often misunderstands or misinterprets the action of others when they lash out because they feel ignored, endangered, or mistreated. So let's take a look at what's going on with Anne right now. Anne's husband, Bill, is standing at the back of the room watching television. Anne walks in and tells him, "You aren't the boss here." Bill ignores the comment and continues to watch TV. Anne comes closer, raising her voice, and says again, "You can't tell me what to do." When Bill doesn't respond, Anne hits him in the arm with her fist. Now, prior to her dementia symptoms, Anne was quite calm by nature and would never have exhibited this type of behavior. But lately, her outbursts are becoming more frequent. Anne continues to come at Bill, who retreats from her and locks himself in the bathroom to avoid further conflict. He does not have his cell phone with him. Since both have been avid hunters, there are guns in the house, but Bill has removed all of the ammunition. So you can see with our little scenario here, we've got a little bit of aggression going on that can cause quite a few concerns. So step 1 is going to be to detect and connect. Did something on TV frighten or alarm Anne? Was it a lot of loud noises? Was it violence on TV? Gently call Anne by her name and let her know that you are there and you want to help before attempting to intervene. And if you think it would help the situation, apologize, apologize, apologize. Then let's go ahead and address some physical needs and rule out medical causes again. UTIs can again be a chief culprit. They can cause pain that the person living with dementia just can't describe. Make sure noise levels are not overbearing. Turn down the sound on the TV. Remove any distractions that could be causing this aggression by turning the channel or just turning the TV off. Try listening to soothing music. Remember safety first for all involved. And another cause could be frustration at not being able to do tasks that were once easy, fixing broken things, using the stove or the oven, or sometimes just even going to the bathroom. We want to address emotional needs. Stress, confusion can be caused by someone asking too many questions or asking someone to do something that requires multiple steps. So focus on the feelings, not on facts, being positive and reassuring. Check on the stress level of overwhelmed caregivers, being cautious not to display fear or anger there. Negative feelings are very easily transferred. So you want to move and avoid things that could be perceived as threats. Reassess and plan for the next time. Avoid being taken by surprise. Make sure that your neighbors are aware of the person's diagnosis. You may have to call on them for some intervention. Safety first. Make sure that you have a plan for protecting everyone in case the aggression becomes dangerous. Always keep a charged cell phone with you at all times, and don't be afraid to call 911 if necessary. If you have to call for emergency help, let the dispatcher know that the person has dementia and alert them to any guns, any weapons that might still be in the home. And once again, a quick poll question. How many of you have had to deal with aggression in someone living with dementia?
Right, we're getting these responses in. This one's a little bit 50-50. Here, I'll share the results. So not as many people have dealt with the aggression as some of the other ones we've gone over so far. And I think aggression, is probably one of the harder ones to deal with because, our reaction when aggression, especially if it's pointed towards you as an individual, is to defend yourself or be aggressive back to the person. And as Cathy alluded, that's never gonna
it's never going to solve anything. It's going to make it worse.
Situation. Yeah. So looking for things to diffuse it are really key here. All right. Thanks for sharing.
Okay. One of the fourth behaviors that is most common is repetition. Persons living with dementia may do or say something over and over and over again, repeating words, questions, or behaviors. These are seldom harmful, but they typically become stressful for us as caregivers. So let's take a look at what's going on with Anne in this particular situation. Anne has recently been concerned about an upcoming visit from her daughter. Though her daughter Katie is not scheduled to visit for another 2 weeks, Anne has begun to repeatedly ask her husband, Bill, when is Katie coming? She asks several times throughout the day, every day, which is wearing on Bill. He finds himself answering impatiently or even ignoring Anne's questions. And at the same time, Anne is going to the bathroom much more frequently than she ever has before, every 10 to 20 minutes. So again, we're going to use step one. We're going to detect and connect. We want to stay calm and behave and be patient and accept the behavior rather than fighting to stop it. We want to look at any physical needs that may be going on here. Anne is spending more time in the bathroom than she normally does. Could she possibly have a UTI or another medical issue? And I know we bring up UTIs quite often. A urinary tract infection in an older adult will cause a lot of different types of behaviors, but for someone living with dementia, it seems to aspirate these behaviors. So UTIs are a chief culprit in a lot of things. Another thing that you might want to do is to consider making Anne a calendar and marking off the days with her until Katie gets here. Big old calendar with big old red X's across. Continue to answer Anne's questions calmly and with brief answers. If the behavior change took place suddenly, it could be as a result of a medical issue and we might need to call the doctor. But not answering Anne's questions are only going to make her repetitiveness worse. So then we want to look at any emotional needs that need to be addressed. Repeat the same answer to help Anne, who may not be able to process or retain your words. Use memory aids like notes, photos, and calendars. Engage in a purposeful activity to distract and redirect Anne's focus. Possibly make a scrapbook with favorite mementos from Katie's childhood. If you see the person living with dementia rubbing their hands across the table or their lap, you might want to offer a cloth and ask for help with dusting or folding or sorting out a junk drawer. Anything like this that can take her mind away from the visit. Then, of course, we need to, again, reassess and plan for the next time. Remember that reputation is a symptom of the disease, and it's the brain change that is causing this repetition as it progresses. Understand that it's not going to be possible to stop the repetition. Keep simple puzzles, crafts, and coloring books available. And if their actions are not harmful, don't worry about it. Find ways to work around it and adopt the who cares attitude. If it's not harmful, who cares? So again, a quick question. How many of you are seeing these behaviors?
Yeah, so I think there's one thing is, on there is remembering the repetition is not going to stop. And it doesn't matter how loud, aggressive, frustrated you are in your answer, it doesn't make a difference. The brain is not retaining the information. So just remember that. So don't be frustrated that they're asking the question. And I think that Cathy will tell you, and I think our last workshop, we went through the GEMS stages. There'll be a time you'll wish they were asking you those questions and engaging in those conversations. And so I think, you always have to look for those silver linings. I've dealt with this before, and I remember the person kept asking me about my daughters. I have 3 daughters, and they asked me every day about how old they were, where they were in school. One of them think about college, which college, and it's like every day, and I got very frustrated. And Cathy, the great person she is, reminded me, she said, look, that is important enough for them to ask. And so the fact that they're asking you about that repeatedly, it's not that they're not retaining your answers, is not a lack of caring. The fact that they keep asking you, it's in their mind, and it's so important for them to get that information is how much they care. And so I think that, just turning that little bit of perspective can help you deal with the repetition sometimes, they can't help it.
So let's go on to our next behavior, which is wandering. And wandering is something that is really something we really need to pay attention to. Wandering and getting lost are common things with people living with dementia, and it can happen during any stage of the disease. If the person living with dementia is able to walk, he or she is able to wander. So let's take a look at what's going on with Ann and Bill now. Ann and Bill spent the early years of their marriage in North Carolina. They moved out of the state into their current home 30 years ago. Ann constantly asked to visit North Carolina. She frequently leaves the house in the morning while Bill is in the shower and states, "I'm going home to North Carolina." She's been found by neighbors on many occasions at their church, on neighborhood streets, and at one time at a very busy intersection near their home. Their daughter, Katie, is worried about potential injury. Bill is also worried and at a loss as to what to do. Bill is logical and tries to explain to Ann the reasons they cannot visit North Carolina, though he recognizes that this approach is not working. This approach also tends to make Ann more angry, and the wandering starts to increase at those times. So step one again is detecting and connecting. Understand that long-term memories are the possible culprits for this behavior. Is Ann trying to go to work? Is she trying to run errands? Is she trying to visit friends? What is the purpose for her wanting to go home? Accept what the person says about wandering being goal-directed. They could be following past routines. She could be getting ready to go to work. She could be trying to go to church. She could be trying to run errands. So again, look for physical needs and address those. Look for pain, as sometimes wandering begins as an attempt to move away from the pain, or is the desire to get away from something else or someone unpleasant. Have there been any changes in routine or daily exercise? Offer to go on a walk or take a drive. I know a lot of people will enclose their backyards and make little wandering gardens outside. That can help with that. Make sure that Ann is not responding to an unmet need. Is she hungry? Is she thirsty? Does she need to go to the bathroom? Try to engage in Ann in calming activities like folding washcloths or sorting colored clothes to prepare for the trip. Okay, Ann, yeah, we can go to North Carolina, but we need to get all of these done first. So can you help me get ready to go? And then, of course, we want to address the emotional needs. Provide reassurance that your person living with dementia is safe and that you are together. Offer to help Ann get safely to where she would like to go, or offer to take her later. And again, using some simple distractions. Then we want to reassess and plan for the next time, because as the disease progresses, there's going to be a next time. So again, you might want to create an environment for safe wandering, like an enclosed garden with circular walking paths. Make physical changes to their surroundings to camouflage them. You might, if they're trying to get out the door, you might want to put a dark washcloth on the doorknob so that they don't recognize the doorknob. A lot of times a dark doormat in front of the door will prevent them from going, because they picture it as a hole or something that could be something they need to avoid. Paint the doors as the same colors as the walls. Could be a little bland, but again, it disguises the door. Consider community day programs that can provide supervised activities. There's a great adult daycare program here in Richmond called Circle Center, and also Innovate Pace. They can provide supervised activities and meet these wandering needs. A really good thing that I want you to consider is to get a GPS tracking device that can send electronic alerts with his or her location in case they get lost or they fall. We here at Assisting Hands have a great little electronic device that we call Help Alert. And Eric can tell you a little bit more about those, but those are really good devices for people that have a tendency to wander.
Yeah, they're just little pendants you hang around your neck, clipped to a belt. And again, they have GPS in there. It's also got fall detection technology in it, and you can call it, they can call. It's a great device. And they're also just came out with a watch version of that, so it can be worn around the wrist. The other thing I was going to say here with wandering becoming an issue, and this is where Brooke and Brookdale kind of gets in, can be a real service, is their memory care unit has the extra additional security. So the person can't, they may be able to wander out of the room, but they're going to be in an area that's controlled and not be able to wander outside the community or other dangerous places. So if wandering becomes an issue, that's when, even here at Assisting Hands, we would start talking to the family about a memory care community. So,
yeah, I think, you know, and another thing too, with our community having, you know, we have two parts. We have our assisted living community, and then we also have our memory care community. And Eric is right. The memory care is a secured environment, so that it prevents, if residents do feel the need to wander or walk or pace, they're never going to end up outside of the building, in unknown territory, in an unsafe environment. They do, however, we have an indoor courtyard though, which is great. So they're able to go outside without wandering off. The difference between assisted living and memory care too, just because it's sometimes a misconception, just because you or a loved one may have a dementia diagnosis does not necessarily mean, you know, if you're looking into communities, for instance, it doesn't necessarily mean that they 100% would be initially right into a memory care community. We have quite a few residents that have dementia diagnosis on varying levels, but they just haven't quite hit that. And the big kind of, like Eric was saying, the big trigger for us is when they do start wandering. That's kind of where we start talking about memory care placement, and it's all about safety. I mean, that's what it comes down to. But we have residents that are that have maybe some confusion, but they're still in assisted living and they're doing great, you know. But we know that when the wandering starts presenting itself, then we have discussions with our family members about their loved ones and making a move to memory care. So.
Safety is a major issue with this.
Wandering's a big one, and wandering is, and it can happen in the evening hours too. That's a really big, sometimes they're a little unsettled in the evenings and they're losing track of time of the day. And so they're up wandering at night when everybody else is sleeping, which can be very dangerous too, so.
Okay, and let's take another little quick question. I'd like to and see how many of you have had experiences with people wandering with dementia. Okay.
So it looks like, yeah, so here, I'll share the results. About 2/3 of the people have dealt with this. And so this was, you know, probably not the one that people have most dealt with, but it's certainly one of the top ones.
So we've talked about some of the top.
Oh, wait, Cathy, we got a question real quick. So
okay,
since it's on wandering, I thought I'd kind of just talk about it. Is it common for wandering to increase during transitioning to a new living situation, and then subside once they are adjusted?
Not necessarily. Once the wandering starts, typically it's not going to go away. It might slow down, but it will remain constant. But it's just a part of their brain. It's taking, when wandering comes, it's usually going back to some long ago memories, what they did in the past. It's wandering with a purpose, trying to get there. That's why it can be so dangerous, and it's really important that we keep the wandering contained in areas where just in case, falls, getting lost, things like that. But I have not, in my experiences, seen wandering ever really go away once it starts. Does that answer your question?
I think there was another question too, that Jonathan had wanted to know, how do you handle wandering that becomes dangerous?
Yeah, I think that, so I'll take a shot at this one as well. As I think that's where looking at a memory care unit is probably where, I mean, you either need to have someone there 24/7 to monitor them to prevent it. But even inside a home where you have stoves and other utilities that can be harmful to them, the environment's not necessarily secure. So, you know, we've seen this with our clients, and that's when we would recommend that they would look at not just assisted living, but actually memory care, because of that additional layer of security, and they don't have access to areas that would maybe provide to be dangerous to people, even in assisted living. There's, you know, areas that could be dangerous to somebody who is not cognitively at their full capacity. So,
and one of the things that I've seen in the homes with people who their wandering is increasing and increasing, so is their curiosity. So you may have to have some locked cabinets where you keep chemicals, medications, things like that. But if they get fixated on that lock, they're going to wander to it. They're going to fiddle with it until they can get it open. And then there are chances that something catastrophic can happen. So when wandering gets to be a really primary thing, my suggestion is to always start to look at a secured area outside of the home. It's just one of the things that we have to do. Okay, so we've talked about some of the 5 most popular behaviors that we see with people experiencing with dementia. And so I want you to remember these 4 steps that we need to understand and address with each type of behavior that we see. First is always going to be to detect and connect, making sure that we can keep it as positive and friendly as possible. We want to make sure that we have addressed any physical needs, both met and unmet. We want to make sure that we have met and addressed emotional needs. And then, as always, we're going to reassess and plan for the next time, because there will be a next time. Okay. Now we've reached the end of our workshop, but I want to leave you with some really good dementia resources. First and foremost is I always recommend Teepa Snow. She is my mentor. She has this thing called a positive approach to care. Until there's a cure, there's care. Teepa is world renowned. She is an occupational therapist that has put a lot of research and effort into teaching and helping people understand how dementia affects not only the person living with dementia, but affects their families and their caregivers. Teepa does a Facebook Live every day, every morning at 8 and 5. She's always giving great tips. She also holds a free brain cafe weekly. You can just go to her website and you'll see a lot of resources that she makes available to people for free. There's also 2 new streaming TV things, Saltbox TV and Peacock TV. They're designed for older people, but they also have streaming videos from Teepa, and they stream her blogs every day. We've also got the Virginia Department for Aging and Rehabilitative Services, or DARS. They're right up the street from us. George Worthington is the contact there. He is a wealth of information regarding anything dealing with aging and elderly people, not necessarily dementia, but a lot of resources there. AARP in downtown Richmond has a lot of resources available. Our good friends over at the Greater Richmond chapter of the Alzheimer's Association, another wealth of information for anyone. They are also in September getting ready to host a dementia workshop that is free to the public. It's going to be, I think, both in person and virtual. You can contact Lisa Greenlee and she can certainly give you more information about that. Wait a minute here. Let's go back to where. Then you've got us here at Assisting Hands. We are delighted to help you with anything personal care, home care, dementia care, and we can offer services anywhere you call home. That could be in an apartment, freestanding home. It could be an assisted living. It could also be in a memory support unit. And then, of course, we've got our good friends over at Brookdale Midlothian. Tremendous resources. Brooke has also an open door policy. She's like Eric and I, willing to do whatever we need to do to help you help the one that you love. So if you're interested in learning any more about home care or home care support, memory care communities, please let us know. We're certainly welcome. Would love to help you.
Great. All right. So while we're finishing that up, Cathy, why don't you talk about our next workshop, and then we can take questions. Either people can unmute themselves or put them in the chat.
We're going to do our next workshop, and this is a really fun one. It's called The Positive Approach to Care, and it's based on Teepa Snow's positive approach and how to support a person living with dementia, greeting and connecting, offering comfort and support, and how to do with the person and not to the person. We'll be doing this Thursday, September the 9th, probably at 10 o'clock, but if we have suggestions for other times, we'll do that as well. It's a great one. It's a lot of fun, and I hope that we'll see each and every one of you there Thursday, September the 9th. If that's the end of our workshop, if anyone has any questions that they'd like to talk about, we're certainly here. Recordings of our workshop will be made available later today. A link will be mailed to our YouTube channel with all of the questions. And also we do offer certificates of completion for anyone who needs them for work or any other type of thing. They are not continuing education credits, but they are acceptable certificates if you just need to prove that you've had some education with regards to dementia.
Yeah. Hey, yeah, so definitely email us or put in the chat that you'd like one. Hey, this is a really kind of tough question in the chat. It's how do you address conversations when they talk about not wanting to be here anymore, suicide, giving up, etc.? That's a tough one.
That is a tough one. That's not one that I have ever personally experienced, but the first thing that comes to me would be to call the suicide prevention hotline. And I'm sorry, I wish I knew that number.
Yeah, well, but I think that's also, but you need to find someone in that, on that service that knows about dementia though, right? It's not just a normal suicide type situation. One is because the cognitive impairment could be contributing to having those thoughts, as well as you know, as you let off this conversation, is the diagnosis is terminal and is progressive. So it's not getting better. So that is a tough one to deal with. So
That's
I would
really,
say it's probably beyond anything that we've dealt with, but definitely getting some professional involved in that has the experience and probably certification to deal with suicidal thoughts and tendencies, as well as somebody who has some experience with the dementia overlay. So
yeah.
And I would also like to, you know, here at the community, but they're, you know, even outside of a memory care community setting, there are geriatric psychiatrists that specialize in, you know, dementia and dementia related thoughts and behaviors in regards to suicidal ideologies, things like that. So your primary care physician can probably put you in touch with or give you a contact or tell you somebody to call, but there are resources out there, which geriatric psychiatry, I would definitely recommend looking into that for sure. And it could be, there could be some sort of medication that he or she is currently taking that shouldn't be, or vice versa. Maybe there's something to help stabilize those moods, but geriatric psychiatry would be a good place to start too.
Okay.
all right, and Daryl, I'm actually responding to your question about the next presentation. Actually, what you can do, here's a little secret, is when everybody who's on this, who registered for this presentation or workshop automatically gets on my list. You'll be invited to the next one. If you register for any of our workshops, then you get to put on the list for getting all the materials and links to the videos for that workshop. So shorthand, Daryl, just register for the next one when you get an opportunity. You don't need to attend, but you'll be on the list to get it all.
There was another question. Lisa was asking, her mom's recently started quietly mumbling to herself. She notices it in the car. She's 88 with small signs starting to show. Is this, should Lisa be troubled by this, Cathy, or is it just part of the disease process?
It's part of the disease process. And it's something that will probably continue. It's typically someone who is trying to formulate their own thoughts, and they're really struggling. And you know, just keep in mind that someone as living with dementia in the beginning, their vocabulary usually retains maybe 2 out of 4 words. As they progress and they mumble more, their vocabulary is going to get to the point where we don't understand them. They're going to start making up words because it makes sense to them.
Mm-hmm.
And it's something that we just have to accept and smile and move forward. It's part of the disease.
So a couple more questions. So one is about links to past workshops. So here's what, again, is when I send out this workshop, the links to it, the link to the recording will be to the actual workshop, but it's on the Assisting Hands Richmond YouTube channel. If you go to anywhere in the Assisting Hands YouTube channel, all of our other dementia workshops are also there. So it's an easy way to get to those as well. And then just if you subscribe and hit the bell notification, you'll get notified anytime we upload any new workshops. I do have a question. Prasad, he's asking, so Prasad had a very insightful comment about just the increasing of dementia due to world populations, diagnosis, et cetera. He's just saying, is there going to be enough care available for, you know, people with dementia? I would say, Prasad, not right now. I mean, we're going to have to do something in order to be ready for that, I think, wave. And so there's a couple of things contributing to this, is just the increasing population, right, is automatically going to increase the rates of dementia. The fact that people are living longer are going to increase the rates of dementia. And those are two things we really can't do anything about, you know, and the whole aging of America, of the world is, we're trying to do that naturally, like we want to sustain life and lengthen life. So, you know, that's one of the kind of downsides of that. The last thing, and I put this in a comment back to Prasad, was our health, especially in America, we're doing a terrible job at our own personal health. Rates of diabetes type 2, smoking, drinking, just eating unhealthy, lack of exercise is also increasing dementia. So if there's a thing you can do to lower your chance of getting dementia, eat well and exercise and sleep. Right?
You know, they're also now showing some correlations with advancing dementia and the pandemic that we're under.
Yeah.
So, you know, the whole isolation, socialization pandemic is a major contributor to a lot of people's decline in cognitive health.
Yep. So anyway, oh, good. Stephanie, I'm glad you put it in there. I was going to call you out. So Stephanie Shanks, I saw in her email, she's with an organization called Art for the Journey. It's a phenomenal, phenomenal program where they actually go into assisted living communities. They may go elsewhere, but I know of them through assisted living communities, and they actually do art with residents, et cetera. And it's scientifically proven it helps with some of the things of dementia. So I don't know, Stephanie, if you want to take yourself on mute and talk a little bit more about it. She put a link in the chat. It's phenomenal. So anyway, Stephanie, if you're still with us, go ahead and I'll give you some time to talk a little bit about it.
Sure, Eric, thank you. Yeah, I'm excited to share a little bit about Opening Minds Through Art, or OMA. It is designed, as you mentioned, by gerontologists. It's a best practice program that's been really successful in Ohio and here in Virginia. The basic design is elders get to make abstract art, which doesn't require recall or artistic skill. And it's a step-by-step process that anybody at any level of dementia or not, just an elder, can feel successful at. It gives them a lot of choice, that creative dignity that making art inspires without being juvenile. They don't have to, you know, do a color by number or paint a pumpkin. It's really open-ended and almost special too, because there's an intergenerational aspect. So in normal times, when there aren't restrictions on having volunteers in homes, OMA partners a younger person, sometimes a college student, sometimes just somebody of a younger generation, to be their partner for several weeks in a row, and they build a friendship. And that younger person just supports them, supports their choices, talks about the artwork, talks about what the colors and images remind them of, and it's just a lot of fun. And the elders, the facilities we've worked with, just get addicted to it. It's the best part of their week. The roster just keeps growing and growing and growing. It's a lot of fun, and
and I'll tell you, Stephanie, the outcome is beautiful. Some of the artwork is absolutely gorgeous.
It really is stunning. We frame the artwork, they name it, we have a reception. It gives them a sense of meaning and purpose, so something larger than themselves, right? It's not just an activity, it's really something bigger than themselves. They're investing in this young person. So there's this,
yes,
they're dignified by the wisdom they can provide.
Yeah, and I think that, you know, and Angela just put a comment in, and she said suggestions for dealing with withdrawals from everyday activities, et cetera. And I think that while I think Art for the Journey is about engaging people, and it does help draw them out of their shells, it engages them with people. And I will say, and again, go visit whatever web link that Stephanie put in there. The art, I'm assuming there's probably some examples of the art. It's amazing, because if you think about it, this is one of the great things is someone's mind who's affected by dementia is thinking differently. Well, that can open up creative channels that they may have not done. And I think one thing about art is just different perspectives on things and how color, and they respond to color and shapes and stuff like that. So it's amazing. So I think that, and I will say that contact Cathy. Cathy, we also work with an individual that's put together dementia activity boxes that we have found that are really great. And that helps engage people in activity. I think that's just part of them getting used to engaging in things will draw them out for other things like talking on the phone and just having conversations, etc. So. Well, great. I'm going to stop recording now. And then we can field questions, and Cathy and I can stay on as long as anybody happens. So stopping recording now. So thank you.